a very dear friend who has, oh God, you weren't there quite at the beginning, but she's an old time QRDG from her Yale days, as is Deanne. And it's always such a pleasure to see these lovely ladies. Shanna Stell is an anthropologist, so I always was appreciative of how she looked at things versus how I looked at things as a psychologist, when it came to HIV things. At any rate, with no further ado, Shanna Stell, take it away. Do you want people to interrupt you, or do you want to save questions for the end?
Let's interrupt me. Yeah.
Okay.
I have some slides, but I'm really more interested in the conversation and the community. So yeah, just stop me.
Great.
Thank you for coming, and I'm just going to share my screen and start this presentation. So this one is called Voices in the Fight: Understanding Healthcare Providers' Role in the HIV Epidemic. And I'm so excited that one of my collaborators is here, Dr. Andrea Dunn, who I'm going to introduce when we do the big photo on the next slide. Um, so yeah, Florida. Let's just start with that. And Florida is always going to Florida. And I also just want to point out that I do think that I have learned how to think and work and think about what I'm saying and negotiate and do it a little bit differently than say how I was doing it when I was a postdoc, in Connecticut at the AIDS program upstairs from CIRA, where it seemed like we were all on the same page. I feel like now I've acquired different skills in trying to get other people to be on board with health equity and uh, systemic racism and just many other things. And so that has required a different set of skills. So um, I want to just introduce the Ending the HIV Epidemic initiative in the United States, where the CDC identified 57 priority jurisdictions where HIV is on the rise, where people are receiving new HIV diagnoses, and overall, the situation for HIV is going in the wrong direction. And so Florida comprises 7 of those priority jurisdictions. And I just want to point out that Orange County is the one that looks a little bit like an elbow in the center of Florida. And there are 2 priority populations there are young men who have young Hispanic men who have sex with men and Black women of any age. And so back in the day when the state of Florida made fact sheets, they made one for Black women. You have to make your own fact sheets these days. But at that time in 2019, there were 20,000 women who were living with HIV, and there were about 530 Black women who received a new HIV diagnosis in 2019. Those numbers have stayed fairly steady since the years of what I call the high pandemic. And so this is why this issue continues to be something that needs to be talked about, that we have these 2 priority populations. Um, and so it's essentially it's been past time to center in particular Black women of any age who are cisgender. Their mode of transmission for Black women is through heterosexual sex, more likely than not with a partner whose status is unknown. And so it continues to be um, an issue that we need to talk about.
So, Shanna Stell,
Yep.
just so that I know that we are qualitative here,
Yeah.
but just so I can understand the numbers a little bit better, the 530,
Mhm.
is the 309 a subset of the 530, or is it in addition to?
My thought that it was in addition to, but I mean, every that there is some conversion from HIV to to AIDS. And so the 309 would have been, in the way I understand it, is that women who had HIV who then received a diagnosis of AIDS.
Okay. All right. Thanks.
Yeah. So in Orange County, so the top pieces of information are coming from the AHEAD database at the CDC, where they're measuring the progress of HIV care and prevention along these indicators. And it's hard to actually tell just the way that these are put together that actually things are going well in Central Florida. It is a place of actually a lot of resources. There are a lot of tools in the toolbox. There are a lot of really motivated people who care about HIV who are either from Central Florida or who have come from Central Florida or come to Central Florida um, to to do this work. And so that's part of why we have this subset of information that of data that we're talking about today is talking to these providers. So, like I said, it's not obvious from just the way these are displayed, but Orlando, which is the main city in Orange County, was higher in the top 10 list of cities in the entire United States for HIV, and now has gone down the list from 5 to number 6 most recently. So things are actually improving, but of course we're not done yet. And then Orange County also has these 3 main goals specifically as part of their Ending the HIV Epidemic plan, which includes making sure that the total number of people getting to virally suppressed is 90, right? Totally in line with the 90-90-90 campaign that UNAIDS has created, making sure that the number of people who with HIV who receive a diagnosis, right? So there's a lot of emphasis on testing in the area, and so that's some of the outreach activities that I'm going to talk about in about a minute. So one of the kind of main hubs of information and coordination is the Central Florida HIV Planning Council, and they are actually part of this larger region, which I think is really interesting because, of course, these counties have no borders, and there's a lot of people who are living and working in one county. And living and working in another. And so it provides an opportunity for people to coordinate resources, to use mobile vans, to drive to all of these places. And so that becomes kind of this broader network of motivated professionals. As an example, they host a lot of they provide feedback on how to use the Ryan White Part A and Part B funds, which can't be used for prevention, which is part of the problem. But then also there are these really active stigma task forces that are trying to get the word out. And so there's actually a lot of creativity that is happening locally. And then, just as an example of that, some of the work that's happening with community engagement are things like HIV testing at a bunch of different locations. The slide on the right is so this is from a meeting hosted by the Department of Health for their Ending the HIV Epidemic series called A Map for Change. And quarterly, there are meetings where all of these different providers and organizers and heads of organizations are gathered together to coordinate their efforts. And so I'm actually really proud of being a part of this kind of network. I'm in an academic institution, but it's been really nice to watch people um, start to kind of coordinate in really interesting ways. And then speaking of coordination, so we are Team Orlando, which is a research team of 3 Black women, 4 Black women. So it's myself, Andrea Dunn, who oddly enough is also wearing green today. Nice touch. She is a pharmacist who also has an organization, a nonprofit called Let's Beehive, which educates women and girls about sexual health and education. And she does really amazing, amazing work. And so through her organization, we just finished a symposium which was 2 days last week, nope, the week before, called Stinging Stigma, which was designed specifically to bring in members of the provider community and right alongside local members who don't have provider training but who care about Black women and who care about HIV to be in the same room to kind of further their coordination. And then on the left in the blue is Dr. Rochelle Joe, who is at the University of Central Florida, and she is a counseling educator specialist, right? She educates counseling educators. So the theory that underpins all of this work, which was funded by Robert Wood Johnson Foundation, thanks for the money, the Interdisciplinary Research Leaders Program, is Black feminism. So it is a theory and method that focuses on Black women's experiences and centers those experiences and centers those people, especially for issues that like health that occur at those intersections of racism and sexism. And so I just wanted to give you some quotes from this recent article that was published in the Medical Anthropology Quarterly that further explain what Black feminist health science studies do. And the idea is about trying to make sure that there is a form of justice embedded into medicine. Because medicine, as you know, right, has not actually had a justice lens and has not always had an interest in fairness because the motivation to diagnose and treat has very often come at the expense of a variety of communities, in particularly Black women. And so what I really liked from these authors' description is that they are unapologetic about it. So our research questions for the project, which spanned 3 years and has just recently officially finished, is this question of how local healthcare providers can prioritize sexual health and HIV prevention needs for Black women. And so the secondary research questions I've put here below. And so the one that we're focusing on today is the provider data that's coming from secondary research question number 3, which is about trying to figure out how local providers are interacting with Black cisgender women. Because as I was saying, there is a lot of coordination, right? It's not Central Florida is not a desert for HIV prevention. There's actually a lot of efforts. Some of those efforts, I think, are what we have been finding are duplicated. And there's some structural issues that are preventing actually trying to connect the people who need this information and who need testing with all of this opportunity for testing and all of these opportunities for PrEP. So we're looking at question number 3 today. So to give you just a review of the total sets of methods that we completed over the 2-year research period, so the fellowship itself for interdisciplinary research leaders was 3 years and our research period was 2 years. We completed 75 one-on-one semi-structured interviews with Black women living in Orange County, Florida. I'm reporting today on some of the research with local healthcare providers. And so it ended up being 17 interviews total with 20 providers. So the majority of those were one-on-one, and then a few of those were in group interviews with 2 or 3 people. And then our symposium most recently was based out of the concept mapping data that we did. So everything is getting used, which is nice. So our community engagement activities for the project involved doing things like attending events that were happening already in progress, accidentally walking into health fairs because it seemed like, and I'm going to get to this, but the health fair becomes this unit of outreach for Central Florida in particular. We created our own events, such as a town hall that happened in August of 2022. We had a networking event with providers in December of 2022, and then the symposium that we just finished a couple of weeks ago. We have been attending some of those events, like the screenshot that I gave you from the Department of Health's Ending the HIV Epidemic meetings. We attended the standing meetings of a variety of local clubs and organizations and just asked for a little bit of time from their meeting to introduce the project. And then we also visited some of the offices of these HIV serving organizations. So busy. Um, just to give you an idea of what is in the local environment, there are better billboards than this that my colleague has actually been featured on. I wanted to show you one that I didn't like. And so there's we want, of course, to make sure that everybody is met at whatever level of an understanding of HIV and what's happening in the community that they are at. But there are just some pieces of information that don't really have enough of a context to even understand why somebody, in this case, right, would need to use a condom or what that's for and why this is an issue in the area. All of that is just kind of washed away. But instead, here is a group that has expensive money, right, to pay for a billboard. Like I said, there are better billboards. Other things that happen in the area is that there are people who have been personally affected by HIV who are motivated to put on and host their own events in honor of their family members and friends who, in some cases, have since died of HIV. And so these are also some other events that are happening locally to commemorate those to commemorate their lives. This is an example of one of them, which was a specific art and health benefit. I wanted to just give you an example of a flyer. And so the health, you could walk into a community center and inadvertently walk into a health fair. And there's so many health fairs that are happening, which is part of the irony that some of this information is still not quite meeting people when they need it. And a lot of people think that this information is not for them. So there are so many health fair events that are happening. A lot of them are put on by local organizations such as churches, um, and they have then the discretion to pick and choose what focus of topics they want to choose. Some are not interested in HIV as far as the groups that they invite for their health fair in their community, in their neighborhood. But the sum total is that there are a variety of opportunities for outreach. As I'm getting ready to explain, that there are also organizations that have vans, and there's still just kind of missing people. I just want to point out that that particular one does mention HIV. It's still not clear, how many people get tested, that sort of thing. So starting to get into some of the data um, from the interviews, I want to actually start here with this quote that I'm calling "The providers are tired." I'm just going to read it very quickly. So I'm only one person. I'll do as much as I can for as long as I can until there's somebody else that's willing to take the baton and carry it on. But I guarantee you, in order to fix the problem, we have to have some type of solution to the problem. We have to bring in more people that look like me. And this person was a Black woman. Because our people are not going to hear from someone that don't look like them. They don't trust them. A lot of people want to say medical mistrust is not real. Yes, it is. It's very real. It's very, very real. Even as a Black provider, I'm a woman. I still need healthcare myself. I almost died in New Mexico from COVID because no one listened to me of what I needed. A lot of the providers that I spoke to for these interviews um, had already kind of been working on HIV specifically, not just infectious disease. They had already put in 20, 25 years. And so, because they are at this mid career point, they are tired and they have personal connections, which is one of the things that I think about going forward is how do we bring more people in who may not have personal connections to HIV, but are still interested. I've put in 13 years working on HIV myself directly. And so these are some of the things that I continue to think about, especially as the HIV pandemic continues to age, as all of us do. Some of the things that I want to um, report on today are some of these structural considerations about Orange County specifically and Florida more broadly. So, one of the things that I always want to make sure that everybody knows is that Florida did not expand Medicaid as part of the Affordable Care Act. And so, that means that there are still not as many available funds as in other states for individuals to increase their access to healthcare by increasing their access to healthcare insurance. Um, Locally here, there is a family tree of HIV related organizations. And so there are people who may have worked at one who then go and form their own organization. And so that is feeding into this first bullet point here about the perceived competition between organizations. So one of the things that I found was interesting from these interviews is that these members of these organizations felt a little bit constrained. I originally thought that that would mean that because they had come from some of these organizations, that they would collaborate a little bit better. But the way it was explained to me is that some of the philanthropy and how they receive their funds means that they're all trying to fight for the same metrics of how many people were tested and how many kits did you use and how much money did you spend on these efforts. And so that means that they actually have been actually duplicating their efforts sometimes. There are only but so many places that are willing to accept local, a van or someone setting up a table. And so they are very often following each other around these different locations in order to find people. And so that is also, one of these other issues. There is an acknowledgement from all of these people that I interviewed that trying to make inroads in the faith community and with schools are both very difficult for their own reasons, right? Some of it is related to law and just how difficult it can be to talk to students, right? And to talk to people who are under 18. And then also with the faith community, there are still quite a few people who believe that their parishioners are not people who have HIV, and so therefore there's no need to do that kind of education. I also just want to mention that in December 2024, Orange County Sex Ed was updated to promote abstinence, and then that was kind of pretty much it. And then because Orange County's curriculum for sex ed specifically, right, didn't get approved by the state, right? So they submitted their curriculum, the state didn't respond. The county, and there were others, didn't actually do any sex ed education for the year 2023-24 because their curriculum hadn't gotten approved. Um, Another issue is that Orlando is perceived as a family-friendly tourist location, right, with a huge volume of people that come through, and that is not only the case. Like that is true, but that is also not true, because there is also a lot of sex tourism. There is a lot of sex trafficking, and the family-friendly perception drives all of the sex tourism and its accompanying behaviors underground. And so sometimes there are the data ends up being a little bit different because some people will go home and then end up with an HIV diagnosis, but that gets identified as being of their state and not to Florida. There are still babies being born with HIV, which, as I think this community knows very well, is entirely preventable. Um, and so I just want to continue to mention that. Um, there is an interest in trying to combine HIV testing because of the stigma with general screenings. And so I have a quote here that says, so sometimes when we go out in the field, instead of saying, hey, we're doing HIV rapid testing, sometimes we have to come from an angle of like, hey, we offer general health screenings. And so if you get on the van and do a glucose test or do blood pressure with us, I might be able to run this HIV test and start to have conversations that way. Um, I think that it's an interesting way to try to kind of bundle the information, co-locate those services, especially because it's still very few people who are interested in getting checked for HIV and other STIs. So some other issues are the organization's operating procedures. There was one person who said that they felt like the operating procedures and how to do this work of outreach in communities was being written by people who didn't have knowledge of these communities or might not have been from some of these communities inside the county and inside the this broader region. And so the people who could provide that information don't have the education level to write the standard operating procedures. And so there's a disconnect there. And so people felt like that was a barrier, right? That they might not have the education, but they have the experience and they have the deep knowledge of these communities. I also just want to point out that there's a lot of people who are migrating to a variety of places. And Florida is this really important hub for not only the rest of the world, the rest of the United States, and also Central and Latin America. And so here's a quote from provider number 5 that I interviewed. Florida makes it easy for people to come in and out for a lot of immigrants, for a lot of people who may be coming in for unstable situations, who don't always have the means to get to care for prevention or know where to find it, or even have a place for care that isn't a language barrier. There are a variety of people who speak a lot of languages here, as is actually most of the country, but that doesn't mean that there are providers on site in house who speak those languages. Um, One thing that I heard people talk about, especially with the Haitian community, is that sometimes because the Haitian community is so small and interconnected, that almost makes runs the risk of it being too close. So that is another issue that perhaps we can talk about a little bit later. So, another issue is that the providers are not screening for HIV, or they're doing all of the tests, which is the standard of care, and then being reprimanded for that, um, which is counterintuitive. So, I have another quote from provider number 2. If we don't have healthcare providers who are properly assessing and screening everybody and not making assumptions of what you think your patient needs and properly screening them and assessing them appropriately is a huge problem. And I just want to give you this quote because I just really like the way the dialogue goes. So I asked the question, do you know a lot of other Black medical providers in Central Florida? This person says. Um, and if I do, they damn sure don't want to do HIV. Why? They don't see money in it. Let's just keep it real. There's no money in it for them. A lot of nurse practitioners are looking into aesthetics, where the money is because everybody wants a butt lift or lips or anything like that. That's the truth. That is the real truth. That is the real truth. They don't have a they don't have passion for it. They don't want to get involved in it. They're afraid of it. They're afraid of it. Yeah, I don't know very many, and the ones that I do know are aging out. But in Central Florida, I don't know a lot of them. Mostly HIV/AIDS providers or anyone that has anything to do with STIs or whatever, they're aging out, they're old. I also just want to mention this particular issue that came up, which I think reflects some of the issues that we just talked about. I'm calling this one, even diverse hiring at organizations can lead to skewed community engagement at those organizations. One of the things that people said was that some of these providers said in their interviews was that depending on who that there was an effort to try to get a diverse workforce, which they thought was overall very, very good and worthwhile. But when it then came to decisions about how the community engagement would happen and how those outreach activities would get organized, those individual people would choose their own kind of referent communities because they thought that that was easiest, and then not do the what I'm calling, my words, harder work of trying to make inroads and do community engagement with communities that didn't look like them or that were perceived as more difficult. So here's the quote. Well, it's not anti-Black. They're scared of the Black because usually most agencies that I have noticed, they will stand and they will hire the white, the Latino. And so when you hire the Latino is going to go, I'm going to focus on my neighborhood. So you're going to skip this population here because you're going into yours. The white ones are going to go like, they're going to say, oh, I'm going to go here. I'm going to go to the gay bars. It's easier to go to a gay bar to get the person to test because I know I ain't going to get no attitude. So we also asked questions about the ways that providers showed commitment to the community, and that ended up being subdivided a little bit further into the ways that people provided personal commitment and how that was sometimes a little bit different from the ways that the organization wanted to show organizational commitment to the community. So some of that involved mentoring other staff members, and the personal commitment took the shape of going the extra mile for clients or patients. So that involved, remember, we've got people who are going back and forth. So that would be allowing them to reconnect and be found on social media, even though that was like their personal social media, in order to use that as a vehicle for the provider to get them back in care. They do things like spend a lot of time tailoring each conversation to each individual person, and that they are making referrals for mental health counseling when they thought that they need it. Um, One person said that they thought it was important to find the right person to do the test. And so I'll let you read this quote for yourself. But what this person said is that they were aware of how they present, um, and how they wanted to make sure that if they thought that how they presented was off putting in a way that the person being tested might want somebody else to do that test for them and to talk to them about what the results are, and educate them, that that person was fully willing to just kind of step aside and essentially sub out with someone who could step right in and do that test.
Deanne has her hand up.
Oh, I can't see anything in my view.
That's fine.
Oh,
That's fine.
yeah,
I can't see a thing.
I will
because you
monitor.
said to ask questions as you
Yeah,
went
please do.
along.
Yeah,
I
stop
was
me.
like, okay, do I wait? Do I ask it
I
now? Do I
can't. Oh
not?
yeah, I should have said I can't see anything.
No, but I
Um,
will monitor, and it's good that that you know that I can monitor it. And I'm sorry, Deanne, if I was late in seeing your
no, no,
hand.
no. It was on this slide.
Okay,
I
perfect.
just had a question about the types of social media. Did they mention which types of social media they reconnected with patients on by any chance?
That particular person said that it was Facebook.
Okay.
Overall, and I can go back and look at this, pretty much all the platforms are in use. One of the really nice things about the Talk Test Treat program locally here in Central Florida is that they use all platforms really well, and they have a really solid social media team. Their game is on point. It's really really good.
Awesome.
But
Thank you.
that was Facebook. Anybody have anything else? Okay. So the ways that providers showed organizational commitment to the community was always a little bit different. And so some of the providers and outreach coordinators, I'm using providers broadly here, they found just some small differences in just the ways that they felt that perhaps the organization was constraining, just because simply it's an organization and um, they have guidelines and things to uphold. Just as an example, we asked questions like, well, how do you show your commitment to Black women? And a lot of times they would respond, well, we are showing commitment to everyone in these ways. Um, and so I know that part of that is because of these kind of broader Florida regulations and guidelines. But I also wonder if that means ultimately that in trying to be inclusive, it is also risking not targeting the groups that we know are getting HIV. So this is something that I continue to think about. I want to read the intentionality quote. My hope is that through the programming and the services, through our outreach and engagement, that people can see that there's an intentional commitment there's an intentional commitment to making sure that Black folk of all spectrums are their happiest selves and their healthiest selves, and that we are a place that anyone can come to and not only be treated with dignity and respect, but can feel like they can see themselves or feel themselves within the space. And then the organizational commitment also speaks to vision. I don't think we've had the opportunity yet to show our commitment and dedication to Black women. I think once we are able to get funding, because it will be billboards all over Orlando with my face and a bunch of sisters behind me. And what I have in mind is she prepped us, something like that. That's my vision for right there. But I just got to get money to put it out. I guess that's my vision. That's definitely something I'm waiting to get funding for. And so we also asked them just some ideas for the future. And some of that involved more direct programming on HIV, that was mentioned by one person, more use of local social media influencers, which of course requires some background information to make sure that they understand HIV and how it's transmitted and how it's not transmitted, and just kind of understanding what's happening as far as the prevalence rates in the community, right, and why this is an issue. Other providers mentioned that they were interested in getting more mobile units so that they could leave the area to talk to, or at least the kind of central urban area to talk to more rural areas and also beyond Central Florida. They were interested in creating safe spaces for Black women to be open and talk about sexual health and wellness. That was specifically mentioned by a few. And then I also have this one, which is for more Black women to be aware that they're not immune, and that, yes, they need to take care of themselves by practicing safer sex. And that if they should know that they're in a relationship with an individual that is a person with HIV, and that they should access PrEP and protect themselves this way as well. So this is the end. I have a couple of questions here that I'll just read so that they get into the audio as well. What, if at all, is new in what these providers have shared about HIV prevention with specific populations like Black women? The second question is how to balance inclusion with focusing attention and resources on the groups who need information and testing the most. And then the third question is asking about Central Florida. So Central Florida is not resource poor when it comes to HIV, and these efforts are making an impact because because Orlando is now number 6. But what should happen in the next few years to sustain these gains? So that's my last slide. I'm gonna stop sharing and I'll leave this up so that we can talk a little bit more. Thank you so much.
That was wonderful. You may want to leave up that slide. I don't know, but that was really wonderful. I had one question while others think about what they want to say.
I'll put it in the chat too.
I understand that, you know, the primary driver of HIV amongst cisgender Black women and white women, probably in Florida, probably would be sexual. But is there, did you have any get any information about substance use at the same time, you know, that you get some kind of perspective on that?
No, we didn't.
Yeah.
If it came up, in the 75 interviews with Black women, for example, we mentioned it. What it seems like is that this particular population of cisgender Black women at risk for HIV in Central Florida is not substance using in a way that is significant or reported in a way that's significant. There are some fact sheets that mention intravenous drug use, but it's always like 1% as far as HIV transmission.
Well, that's good to know as well. Any other comments from anybody?
I have a comment, but I have forgotten how to raise my hand, so I'll just
Oh,
shout
that's
out.
okay. Just speak out. And
Okay,
for
sorry.
everybody else, just speak out.
Hi, Shanestelle.
Hi,
Really
it's good to
nice
see you.
Yes, and it's been a really long time and fantastic work. Congratulations.
That's right. We're not going to talk about how old we are.
Well, we're young. So I was just thinking that the questions you have posted at the end of your talk are really questions, but I don't have answers. But I have another question that might kind of maybe help to answer yours, and that is, in the current climate with so many things happening politically and socially and so fast, do you see any word in the community of just like, how are people processing that, and how are, you know, providers, but also members of the organizations with whom you've been working feel about all of that? Like, what do they do? What are their emotions? What are their actions? Do they feel that, you know, we've been around for a long time and different things come and go in ebbs and flows? So there is maybe no need to do anything differently, or maybe there is. So that's kind of like an empirical thing, but also maybe a philosophical. And so whatever you would comment.
Yeah. So I, for the most part, most recently have been talking to students, my own students, about some of these most recent administrative changes, especially at the federal level. And I've been trying really hard not to react too much, especially because everything is just kind of subject to change so quickly. Um, but I haven't had a chance to talk to some of these providers most recently. My impression is that, um, my guess, honestly, is that because the funding has already been constrained and because some of these, I don't know, I'll just say like anti-DEI, right? Anti-diversity, equity, and inclusion efforts have kind of already been in place, that there's already been some practice in dealing with these things and it was already kind of difficult. So I know it's more difficult now, but I wouldn't think that things are too different, but just more constrained. And I'm going to invite my colleague Andrea to jump in and also weigh in because she is a clinical provider right now.
Because partly, so that's very interesting, because partly what I was thinking is that whatever they keep doing the same way might be this fundamental quality that is timeless, and that might answer some of your questions, in a way, so that they do have priorities and they themselves somehow know what the right priorities are, no matter what kind of vibe is out there. They still know what is the best thing to do and the right thing to do, and probably there are some good reasons for them choosing that. So kind of like not even trying to give them the new answer, but saying, well, what do you feel in your heart like the answer is, because most likely they already know that, right? Yeah, but maybe they don't. I don't know.
Hi, yes, I think that this is a great question. And I think that when it comes to providers, they tend to, I feel like, look at HIV as almost like a silo, and it's just an infectious disease provider, and they'll just refer out. And they don't really, I think, take ownership, especially when it comes to the prevention methods for screening and testing, and then offering prevention treatment options. It's almost like it's treated as a separate entity, and it's not necessarily in their comfort zone in order to properly manage and screen and provide the care that I guess a patient would need. So they tend to refer out to either the health department or to an infectious disease clinic. And oftentimes, a lot of the patients don't want to go to those places. They feel more comfortable with their personal providers. And so this was one of the reasons why we wanted to try to help identify like where are those gaps between these two populations, between women in the community and then also with our healthcare providers, and how can we bridge that gap in order to help I guess women be able to feel comfortable talking to their providers about these things, and then for providers to be able to identify that there is a need and see the need and be willing to help be a part and an impact of that need. And so it's definitely like a catch-22. And I think that there are providers who do care, but I think that there's a huge level of discomfort. And I think that there's a lot of implicit biases that's happening that's preventing them to care for patients when it comes to alternative lifestyles, or a lot of misconceptions of what they think, or when Black women being hypersexualized when seeking preventative or STI treatment or STI testing. I think as even as a patient myself, and I've talked to this with our research team, and I've shared this with Shauna Stell and my colleague, Dr. Joe, all the time. And we share these stories even as we go to the providers' offices and, our patients, and on the other side of that realm, that oftentimes, being able to feel comfortable speaking up and advocating for yourself. Sometimes it can almost be like a tug of war because some providers feel like they know best, or it's a time commitment, I think, as well. That's a limitation for them with the time that it takes in order to provide those test results, as Sean Estelle mentioned, and how some of the providers, they're tired. They really are. And I think that they feel like they're not equipped in order to handle it. And so that's something with Let's Beehive that we're hoping that we can try to help mitigate, as well as a lot of other organizations like AATC, who are really trying to help healthcare providers in order to feel better and more confident and comfortable, because PrEP and PEP, for post-exposure prophylaxis, both of those medications can be prescribed by a primary care provider. You don't necessarily have to be an infectious disease specialist in order to prescribe those medications. So there's no limitations there, but it's a comfort level. And so that's where I think some of the biggest barriers are that, we'll have to really work hard to address those.
Two things that were disconcerting, what you're saying, Andrea, and something that Shanna Stell said earlier, as far as the discomfort in these providers. We are about 30 years into the epidemic. Those old fogies, I would be one of them, are leaving, and it should be replaced by, I assume that you're going to mostly primary care kinds of providers. When you're talking to providers, you're not going to, subspecialists.
You mean for the set of data? So we talked to primary care providers and anybody who is involved in the outreach part of an
Yes.
HIV serving organization.
Yeah. I was thinking about what Andrea said, that, of those providers, the prescribers, I like to call them, as opposed to providers, because I'm inclusive too of everybody who's got direct care contact with them. You would think that would have remedied itself to a certain degree over time, that there would not be that level of discomfort, because they should be getting it in medical school, or in nursing school if they're an APRN. So that is kind of distressing. The other thing, and I don't know, Shanna Stell, this would be probably more for you. I mean, I remember I was at NIMH when 076, ACTG 076 came out, which was a sea change for vertical transmission of HIV. I am stunned that anybody who is pregnant, so, is not screened. So is it a matter of they're not going soon enough? Even if you go late, I think they still start you on HIV meds, regardless of where you are in your pregnancy. I'm not as confident about what I'm saying right now, but is it that they're not going to the obstetrician or their primary care as soon as they can, or are they not doing it, the screens, the providers?
Do you want to answer that one, Andrea? Because you're at
Yeah, sure. Unfortunately, it's just not happening.
But why?
There's not a consistency, I think, in primary care. And that's the part that we really don't know. I think for the most part, depending on where people are going, if they're using urgent care, emergency departments, if they're not in primary care, using clinics and things of that sort. So they may not necessarily be in environments where they have more resources in order to do that. Oftentimes too, they're afraid of giving a positive result. And I think that there's some discomfort there because they may feel like with the type of testing that is used, for example, like they may not be doing rapid testing in urgent cares or emergency departments where they can get results back within, 15, 20 minutes or less. So oftentimes, depending on the type of test that they're using to test patients, if they use specifically like in hospitals, doing a PCR, it may take 24 hours or longer. And so they may test a patient and then they leave the facility if they're not admitted into the hospital. So just, I think when you're looking at different providers, it depends on the type of test that they're using, if they're rapid or not. If it's a send out to a medical lab, are they obtaining the results there, which in primary care, they don't. They'll send you to the lab with lab orders, draw it, and it takes time, and so there are delays there. And I think that they don't want to be able to disclose over the telephone. You have to have the, face-to-face. Specifically, there's laws around that. I know in different states, there's different requirements, but so for other sexually transmitted infections, some of that information can be disclosed over the phone with test results, or now with our medical apps, where you can see your own test results through My Chart, for example, with Epic. There's different opportunities or ways, but even still, if a patient can see their own test results, they still need the counseling portion after, if someone is newly diagnosed. And I think, to my knowledge and what I see in clinical practice over all of these years, that is the part where I think that there some hesitation and fear around delivering a possible result. And then, as we know with what the CDC and a lot of changes that we're trying to have is a status neutral approach when it comes to testing, and not necessarily focusing necessarily on individuals who are positive, but also incorporating preventative options for individuals who test negative, and what did they do, and what proper education or resources are provided to individuals who are negative in order to help them stay negative. So there's, between that status neutral continuum, there's things that we can do on both realms of that chart. I don't know if you've ever seen it before. I'm sure maybe you guys, I'm sure you probably have, but there's fear and stigma. And that's why we did Sting and Stigma in Healthcare, because, we have to work on that. And it's so embedded, especially in the Black community, with medical mistrust and, this perception of being difficult patients when we're not. And I think that oftentimes there's still preconceived thoughts. And so it's just like a battle between the two. And that's what we wanted to do with our event, was to help people be seen holistically. So,
Yeah. Well,
yeah.
This has been fascinating. We're getting almost to the top of the hour. Any concluding remarks that either one of you wish to make?
I think Shauna still did a remarkable job, and I'm so happy that I was a part of this research team. I say this all the time, but Dr. Joe and Dr. Brown, they have been answered prayers for me, to be able to work alongside them, learn from them, and we learn from each other. It's just been such an amazing experience, and so I'm just really grateful for the opportunity.
I think this was a wonderful presentation. Keep up the fight, ladies.
Thanks. We don't have a choice, so.
Well, you do have a choice, and you choose to keep up the fight.
Yeah.
So you do the right thing. All right, everybody have a nice weekend. And next month,